Okay, welcome everybody to this workshop where we're going to start to apply some of the principles that I outlined in this morning's presentation. So I'm really keen for today to be nice and interactive. I want you to ask lots of questions. I really want you to have the opportunity to actually start applying some of this. And we do have a case study. You should have in your pack a copy of today's slides. You should have a case study by the name of Sky, and you should have some questions relating to that case study. Everyone got that? Fabulous. Please feel free to interrupt, pop your hand up if you have any questions as we're going along. I have put in the workshop pack. Sorry, let's go back. So sorry, I'm rushing because we've actually only got until 1 o'clock. So let's do this. We've got 45 minutes. So we're going to review very quickly some of our ICG research, but really only just so that if anybody has any questions on any of that, this is a really nice forum to start to discuss that. I wanted to talk about clinical assessment techniques that can help us to infer what these drainage patterns are in people, so that we know where is there likely to be dermal backflow in this limb, and so therefore where does my massage need to be nice and firm and slow. We want to talk about some of the manual lymphatic drainage techniques and sequences. Now, in this time, we really don't have time to go into the detail of our massage sequences. I guess the idea is you'll tailor whatever massage sequences you're currently using and the techniques that you're using, and with an understanding of where you're taking that fluid. You're all experienced therapists, so you're going to be able to come up with a technique for yourself or a sequence for yourself that you feel might be more effective. And then we're going to talk just very briefly about prescribing compression garments. And again, I understand that a lot of you use fitters in America that come in. Do we have any fitters in the room? No? Okay, no problem. But you, as therapists, as CLTs, you're all actually making the compression garment prescription in terms of fabric, class, style, and really the fitter looks after the fit component. Yeah, okay. All right. So in your packs, you'll find you've got the drainage regions information for the upper limb, for our cancer-related secondary lower limb patients, and for our lower limb lymphedemas of other causes. So I'm not going to go through those because you've got the numbers there, and I think I've described the principles reasonably well. Hopefully I described them reasonably well in the first session. Does anybody have any burning questions about those regions? Have any comments about the incidents that we're seeing in those numbers? Good question. Now, do we have a microphone? Because I think we've got people on Zoom. Welcome to the people on Zoom. People on Zoom that will benefit from having the microphone.
Question was, how long have you implemented the ICG before you actually did the diagnostic?
As in, how long is the dye in the limb before we can establish what the drainage region is? That's a very good question. And the answer is it's variable. In an upper limb, usually within 45 minutes of injections, we can see where those drainage regions are, particularly if the region is to that original ipsilateral axilla region. In a more, a limb that's had to work harder in order to problem solve its way to that drainage region, it can take us longer because the fluid is moving in that dermal backflow pattern through a larger proportion of the limb. So if you imagine a leg that's untreated, so somebody turns up with a big congested leg, we've got lots of fluid sitting stagnant in those dermal capillaries. We also have a lot of interstitial fluid sitting stagnant in the tissue, can't make its way into the system in the first place. So somebody in that situation where they're draining to the contralateral inguinal region via the pubic area or to the gluteal region around the lateral upper thigh, it can take us sometimes an hour and a half to get the fluid there. And there are other instances it's less likely to happen, but some instances where we just have to, we say it's an unspecified drainage region because we can't move that fluid any further than perhaps the knee if it's a really congested, untreated leg. Does that answer your question? Excellent. Does anybody else have any questions on those regions?
So are you saying that it takes you an hour and a half to get a congested person's fluid into one of these compensatory areas?
Compensatory regions, it can do. From injection in the foot. So if we were to inject a normally draining leg in the foot, and we occasionally do this, and we often do it in patients with a unilateral presentation where it may be a primary lymphedema, because we often see that primary lymphedema patients may have some form of impairment in their unaffected leg, even though there may be an absence of visible swelling in that leg. So we always inject both legs when we're doing a suspected primary lymphedema. If we inject a normal leg, it can take maybe 5 minutes to see that fluid make its way to the ipsilateral inguinal region if we're not massaging the leg. So you can sort of see in contrast the slow transit time of fluid. It may still be draining to the ipsilateral inguinal region, but if it's draining there via that compensatory pattern known as dermal backflow, it slows everything down. So you can see how the transit time of that fluid, it's accumulating all day, every day in the interstitium. It's leaking out of our blood vessels and into the space. You can see that reduced transit time for that fluid to make its way out of the leg can result in that net effect of swelling if the transit of the fluid is slower than the rate at which the fluid's accumulating in the limb. Yes?
So does the amount of time that it takes for the diet? So the amount of time that it takes to reach those areas of drainage, does that affect how long you would then spend on MLD in your treatment? So for those patients that have a shorter time getting to where it needs to go, would that be a shorter sequence or less time versus that person that you said is really congested?
Yeah, look, I would like to think that we have the luxury of time in our sessions to be able to translate that, what we're seeing. I think realistically for all of us, we have a set amount of time with our patients in our sessions, and it depends on patient goals in terms of what we're achieving in those sessions. So well, I'd like to say yes. I think what we're more likely to do in a really congested limb that we see it's taking ages for that fluid to make its way to the region, we would be more likely to implement really good evidence-based CDT principles and decongest the leg. And then what we do often see if we do a repeat ICG after CDT has been implemented is that we have a better chance of being able to establish the drainage region in those cases where it may have been previously unspecified. So it's more about good evidence-based treatment rather than just focusing on massage for a specified period of time. Good question though. Yeah.
Hi, I'm just curious with the percentages where the transport goes to the original at-risk side. I'm just curious, is there any sort of tipping point that you've noticed where if there's more nodes that were involved or taken out or radiation to the area versus not, is there any sort of data or anything you've observed that has changed that drainage pattern? Do you know what I mean?
Yeah, look, we tend to look at it in relation to the MD Anderson cancer staging scale. So it's more that we see in the earlier stages, in the milder cases of lymphedema, we do tend to see drainage maintained to those original regions. But as for whether it's a bit of a chicken and egg situation, is it going to the original region because it's milder lymphedema, or is it a milder lymphedema because it's draining to those original regions? In terms of, I think Louise was asked a similar question this morning, have we done looked at the correlations between radiation and where a patient's draining? Not at that level of detail, no. But we did point out that 90% of the arm lymphedema patients that we included in our data had an axillary lymph node dissection. So it's pretty extensive surgeries. What we do see is patients that have, when you see really severe skin changes, really severe fibrotic changes, a lot of range issues through the shoulder, that they tend to be the patients that are less likely to drain to the ipsilateral axilla. The other patients that are less likely to drain there are those that are tricky to manage. So you might have done, you might have done 3 weeks of bandaging with them. You might have transitioned them after bandaging into some really good garments, some flat knit, custom made, class 2. We use a lot of sleeve and long glove combinations where we see a lot of dermal congestion through the forearm. So they might be in that really good combination, but their measurements, they might have a volume difference that's still up above the 20% mark, even though you've been through really good, what we'd consider best practice management. They're the patients that are more likely to be draining to those compensatory regions, because our interventions, while they might be best practice, if the body's way of compensating is complicated and tricky, then it stands to reason that we're not going to get the same sort of outcomes. So you can sort of use your clinical tools to infer where they might be draining to as well. Okay, we might move on. So what I do want to talk about today is to give you some really good take-home information, things that you can start to apply in your clinics in terms of where do we infer the presence of dermal backflow. So we'll talk just a little bit about dermal backflow and the way it behaves. So it will only go where it wants to go. So we saw that in this morning's video, and it will move towards one of those viable drainage regions. It's as efficient as it can be. And you saw that in Fiona's presentation, that depending on the severity of treatment, it will go, if there's a viable region or a nearby collector vessel, that's the first place it will go. And again, it moves towards an area of least resistance, I guess. So it will move towards a collector vessel if it can do. And that's dependent on the extent of treatment or the extent of the damage to the system. More complicated compensatory patterns correlate with a high severity of lymphedema, and we've covered that this morning already. No two people's compensatory drainage is the same. And that's the fascinating thing about working in this area, is that with normal anatomy, we do see similarities. There are these anatomical variations that we see between people in normal anatomy, but when it comes to compensatory drainage, no two people's drainage is exactly the same. And I think that's why you can put two different people presenting in a similar fashion in exactly the same compression garment, and they'll respond differently. And that's where we as therapists and our objective measurements are so important in helping a patient to determine their optimal dose of compression. So I believe that the dose of compression, so the class, the fabric, the number of hours in the day that a patient wears, because everybody compensates differently, therefore everybody needs a slightly different amount of intervention in order to get their transit time to the point where it will actually start to drain effectively. And that's, I explain that reasonably well enough? That's why it's so exciting working in this area, because there's no one size fits all. It's really a relationship, and having that relationship with your patient to work out in terms of their management strategies and their self-care regimen, what it is that's going to work for them based on their particular compensatory patterns. And sometimes dermal backflow will move towards those areas with no underlying lymph nodes, to those deep entry points. So the first thing that we need to do in inferring if dermal backflow is present in a limb is we need to ask ourselves, does the patient have a history that indicates lymphatic impairment? In the upper limb, are we going to see a patient history indicating lymphatic impairment if the patient presents to you with swelling? I'm talking about clinically evident swelling here, not patients that are at risk. We are, because 99% of cases, possibly even higher, of clinically established arm lymphedemas that walk through your door, they'll have that arm edema because of some sort of insult on their upper limb lymphatics. So generally our arm patients, if they present with swelling and a history of cancer treatment, you can bet your life on the fact that there'll be dermal backflow in that limb. That's not the case in the lower limb. And I alluded to this in my presentation this morning, that there are certain lower limb patients, and they'll report a history of chronic edema for, well over 3 months. We'll put them on the ICG table, we'll inject them, and whoop, what do you know? They've got these beautifully structurally intact collector vessels. So in this instance, we refer to this sort of edema as a high output failure. Is that something that's covered in any of the trainings, differentiating between, the high output where we've got a fluid overload versus a low output failure or that mechanical edema? Yeah, so what we've found is lipedema, patients with lipedema that have that fluctuating swelling and pitting edema in their feet, more often than not, they have structurally intact lymphatic collector vessels. Some vascular edema patients, dependency edema, they'll often have structurally intact collector vessels. There was another sort of edema that we spoke about this morning, and I thought I must remember to mention that one as well. Anyway, that escapes me. But there are certain presentations that will have structurally intact collectors. And for me, this was a real light bulb moment, because I knew intuitively that explained why some patients coming into my clinic before I had access to ICG, I could put them in a class 2 flat knit, or I could even put them in a class 1 flat knit, and their swelling would go whoop, and the next week they'd turn up and their legs looked amazing and they had ankles again. And I thought, what's going on here? Why is it that some patients with lower limb edema, the dose of compression can be lower and give them a really good outcome, but some of our cancer-related lymphedema patients, if I tried to put them in a class 1 flat knit, it just wouldn't touch the sides. So what we see if a patient has structurally intact collector vessels is their compression doesn't need to be as military, and their massage doesn't need to be as firm, because with intact collector vessels, all you really need to do is put your feet up against the wall and go for a walk, and that's going to get that fluid moving. Okay, so, sorry, going back to where I was, the first thing we want to ask ourselves is this patient likely to have dermal backflow or not? Once we've answered that question, sorry, that was just a little case study of a patient that presented to our clinic with a 6-year history of chronic edema, and that was her ICG pattern. So no evidence of dermal backflow. Would I put that patient in a circular knit garment? Probably not. It's not going to be great at her ankles, but a class 1 flat knit, and the pitting edema in her feet was almost instantly gone within a week or so. All right, so in inferring where dermal backflow may be present, these are guidelines. This is not cut and dry, but these are guidelines. If the patient has pitting edema, or on palpating their skin and tissues, if thickness can be palpated anywhere in that limb, then you can almost bet your life on the fact that dermal backflow will be there. Okay, so these are at our cancer-related legs where we know they've had impairment to the lymphatic vessels, and in our arms. If the limb above or below the, I always struggle to articulate this one. So if they're pitting anywhere in the limb, it's likely to be there. Above the elbow and above the thigh can feel soft and fatty and not have any evidence of pitting, and dermal backflow can still be there. So there's something about the fatty areas that seem to be able to accommodate dermal backflow without it being obvious and evident. So don't assume that it's not there if it's not pitting in those fatty regions. But above the elbow and above the knee, if the volume difference is significantly larger than the other side, that can be a little bit of a clue that perhaps we are dealing with backflow in this area. So if you're massaging and you're not sure, always be firm and slow, because a firm, slow massage won't damage or be counterproductive if there are in fact collector vessels in that part of the limb. So there's a high correlation between where patients report their problem areas to be and where we find dermal backflow. In fact, when we finish and we mark the outskirts of the dermal backflow area, patients will often look down and go, yep, I could have almost drawn that myself, because they know where the swelling is, they know their limbs, and there's a high correlation between the patient self-reported congested area and where we see dermal backflow. So do get your patients to help you. And if you do have access to a lymph scanner or a moisture meter to get either tissue dielectric constant or percentage water content, if you're comparing skin water from the affected limb to an unaffected limb, where there's an elevated TDC, we do often see a correlation with dermal backflow presence as well. Okay, let's move on. You can, yep. So the interesting thing is the hand and the foot, and we're going to talk a little bit more about the hand and the foot, is that often if there's no clinical sign of swelling, there may not be dermal backflow in that area. So let's have a look. Let's have a look here. So in the hand, this is an ICG of somebody that presented predominantly with swelling in their arm and not a whole lot of pitting through the hand. So this person had collector vessels maintained from the hand up into the arm. Again, seeing patterns like this, having light bulb moments and recognizing that some patients can get away with managing arm lymphedema in a C to G sleeve or a wrist to axilla sleeve, and other people really do need that hand piece. Now, I always prescribe a handpiece for my patients, regardless of whether I think there's backflow anyway, because I think for high risk activities like flying or, you know, if they're going for a long bushwalk, then recommend they do wear the hand. But this is sort of nice explanation, I guess, as to why some people seem to be able to get away without managing the hand too aggressively in terms of compression. What I would say in this instance, while we're on this slide, is these patients, we really need to be careful about garmenting at the wrist. And that's why I ask if there are any fitters in the room, because I think that would be something that they would then control the actual measurement around the wrist. I always, if I'm doing a flat knit custom made garment for this sort of patient, I'll always add at least an extra centimetre to my seam measure to ensure that we don't end up squeezing the wrist too tightly and causing an obstruction of those nice collector vessels out of the hand, because the last thing I want to do is give somebody like this hand swelling because I've occluded that nice drainage out of the hand. Here's somebody who wasn't so lucky. So we can see the hand dermal backflow is actually in the dorsum of the hand and has travelled into the fingers. And in this person, their body's way of problem solving, that dermal backflow actually had an easier route moving in a distal direction between, is it going between the fingers and coming onto the palm of the hand and then draining via the anterior forearm. So something we often do for patients with tricky hand or dorsal swelling is encourage them to do a lot of MLD through the anterior forearm in case their body's using that pathway through the fingers and via the palm of the hand. Same goes for the foot. This person, we can see a lot of dermal backflow on the foot. It's actually traveling via the sole of the foot and refluxing into the toes. In the hand and the foot, fluid will move in any one of those directions that you can see depicted with arrows on those charts. So the hand, it'll go between the fingers, it'll come around the sides of the hand. If that's the way the body can move that fluid more efficiently, that's the way it will go. The foot, we don't tend to see fluid draining between the toes, but it will go around the medial and lateral side, with the lateral being the most commonly observed pattern. Okay, now you guys have got this information in your packs, so we might actually, in the interests of time, got a nice video there, but I think we might move on to our case study, I think, because I'm keen for us to be able to do a bit of interactive stuff. So the next couple of slides just point
Before
out.
you go into the case study, can I ask a question that's come up online in a
Of
couple of
course.
varieties?
Yes.
A couple of questions having to do with what about abdominal and breast drainage patterns and sites? Can you give us any insight on that?
Yeah, so breasts are interesting. One of my colleagues, Asha Hayden-White, has done a study into breast edema and the drainage regions of the breast. And what she found with her study is, again, it was small numbers, but what she found is that the breast will drain in a number of different directions. So it will potentially maintain drainage to the ipsilateral axilla. It will also move in a contralateral direction, and we sometimes see breast dermal backflow dropping down beneath the breastbone to the parasternal lymph node region. Like we saw in the ICG depiction, we do sometimes see the fluid switch at the midline to a collector vessel on the unimpaired side and drain across to the contralateral axilla region. We see breasts drain up towards the clavicular region, and we also see them drain laterally towards the chest wall, and we sort of see the fluid extend and then disappear. We believe it's dropping between the intercostal spaces and into lymph nodes behind the ribs. So again, Fiona calls it detective hands. So we wouldn't do everything all at once, but we might try one or a couple of those regions, inform our patients that they're likely draining in one of those regions, and get your patient at home experimenting with moving fluid in a particular direction to try and find one of those ways that seems more effective than others. The thing with understanding where you're taking the fluid and how you're getting it there is if you're using a slow, firm massage in the direction that your body wants to drain it, you will notice a difference. And in the breast, you'll notice that difference quickly. It's a little bit like the head and neck in that the fluid doesn't have that far to travel to those compensatory regions. So you should, with a breast, be able to feel a palpable difference within 15 or 20 minutes if you've nailed your drainage region. The abdomen.
Well, the other question was, how does the extent of axillary dissection affect the flow to the ipsilateral nodes, if you know that?
There seems to be a huge variation in the number of nodes that people have in the armpit, and there are studies into number of lymph nodes between people in normal conditions, and there's quite a lot of variation. Even in the case of patients describing a full axillary lymph node clearance, they can be talking, sometimes, it varies between people, but my surgeon gave me a full axillary lymph node clearance. I've got nothing left there, so I'd be surprised if I was draining there. We still see that there's something there, and that can be quite frightening for patients if they feel that they needed to have that clearance in order to clear their body of disease, and we start saying to them, actually, you've still got nodes in there, and we can see that because your body is still draining to that region. So we're quite careful in explaining the anatomy of lymph nodes, and that the nodes that are left in that dissection are likely to be at such a deep level that the disease wouldn't have, it's very unlikely to have spread there, because all of the nodes that may have had that metastases would have been taken in the clearance. Yeah, hopefully that answers that question.
Thank you.
Okay, so just at a high level, and I've alluded to this in my presentation, we do have two sequences for both the arm and the leg, one draining to the original regions, and then our complex, which drains to the compensatory regions. Let me talk about the leg. Rather than directing fluid to the inguinal region, we actually start on the abdomen and we direct, thank you. We direct fluid with the patient inside lying. We start to direct fluid around to that gluteal region in the first instance, and then we might roll them onto their back, and we'll show them how to clear across the pubic region to the contralateral inguinal nodes. That's after the patient's done all that preparation and deep breathing and getting the deep lymphatics stimulated. So we'll do that clearance, starting at the suspected drainage regions and clearing that area first before we then move on to the leg, and then we'll start bringing fluid to the ipsilateral inguinal and to the gluteal and to the contralateral inguinal, and then we work our way down the leg like we would with any other sequence. The interesting thing about the pathway that we see with that contralateral inguinal pathway is that it's much lower than we ever imagined it would be. So I always think of that interinguinal anastomosis. I think that might be what I learned. I sort of pictured it being kind of up about here, but it's actually really low. When it crosses the pubic region, it tends to be right down at the pubic level of the pubic symphysis. So we teach our patients low and slow. And often I'll actually use the patient's hand, get them to pop their hand there, and I'll drag their hand across to show them the sort of desired speed and pressure that we're wanting to use there. Okay, now let's meet. So you've got all of this in your packs. We've only got 15 minutes, actually less. We've only got 12 minutes to go. So what I'd really love for you to all do is to have a quick read through Skye's case. In fact, what I'm going to just quickly, because I'm aware we've got people at home on Zoom that don't have access to the paperwork that you guys have, I'm going to quickly read through Skye's case. So Skye comes along to your clinic. She's 45 years of age, 84 kilograms. Sorry, that makes her about 185 pounds, I think. She's got a BMI of 30.9. She's actually American, and I didn't even make her up for this group. She's an American lady living in Australia with her Australian husband. All of our case studies are based on real patients in our clinic. So Skye was diagnosed with uterine cancer 3 years ago. She had a hysterectomy and pelvic lymph node dissection. She didn't have chemo or radiation. A year ago, she began to feel fullness in her left thigh. She also reports sporadic swelling in her ankle, particularly if she's been standing for long periods of time. When her ankle feels particularly swollen, she wears a thigh-high circular knit compression class 2 stocking that she purchased online. This used to help her swelling symptoms a little, but lately the stocking's been less effective. She's not had any other treatment for lymphedema, and she's not seen a therapist to date. No comorbid conditions. She's otherwise quite well. She's on letrozole as the only medication. She works full-time in banking and risk management. She lives with her husband, Mark, and her two sons. She exercises. She generally attends a cycle class twice a week, but she's really had less time lately. Work's been really busy, and she reports that she's gained weight because she's not been able to exercise, and she's probably not been watching food choices as much as she used to. So her goals are she wants to reduce the swelling in her leg. She wants to fit into regular size clothing. She wants to understand what's happening in her leg. She's, a bit fearful of her future, and she has heard of this condition, lymphedema, and she wants to just stay on top of things. She's keen to increase her exercise levels, and she is keen to lose the weight that she's recently put on. On assessment, Skye's skin condition is a little bit dry but intact. She's not oozing anywhere. She's got deep pitting present in the left medial thigh. Her left buttock feels firm and thick. She's got deep pitting through the left lower leg and mild pitting through the posterior medial and lateral malleoli, and mild pitting around her left knee. Her stemmer sign is negative. She has no swelling or leakage and from the vulval region, but she does report intermittent feelings of fullness across that pubic region. Her LDEX is at 23.8. That's a unilateral LDEX. She's got a 26.6% overall volume difference. Below the knee is 15.7 and above the knee is about 30.5. So I'd love you just to spend a couple of minutes chatting to the person next to you regarding the questions that are on the final page. And for the people at home, I'm going to just pop those questions up on Zoom so that you can have a look and have a think about those.
So now that you've had a chance to discuss, I'm going to pass the microphone around and have some of the groups give us some of their input from the discussions.
So we might hear from table 1 on the first question. So supposing that differential diagnosis has been considered and any further investigations have come back NAD, what's the most likely cause of the swelling in Skye's leg based on her history? Sorry, this is bread and butter. You all know the answer to this. That's why we're all here. She's got
Lymph node dissection.
yeah, the lymph node dissection. She has lymphedema, doesn't she? Yeah. Sorry, that was almost too simple that I confused you all. So I'm going to stay with this table because it builds on that. So based on this diagnosis, is it likely that there'll be dermal backflow in Skye's leg?
Yes,
Absolutely.
Yes.
Why?
because that's where it's trying to go.
Because the lymphatics are impaired, aren't they? Her little her little train track has
Mhm.
been disrailed. And so that fluid's having a hard time getting out of a leg.
Yeah.
Excellent. Well done, table
So should
1.
we, so my discussion, I mean, I guess I was the only one who was talking at the table for the most part, but sorry, you mean to usurp all the time. But should we be more assertive in giving patients the options of waist high something or other? You know, when we are seeing that muffin top, you know, at the top of the leg, or we're seeing that fluid accumulate in the back of the hip. I mean, I do present that as an option to patients all the time, and of course,
Mhm.
most of them poo-poo it. Nobody wants to wear
No
that.
one wants to pull on an
But-
AGHT, do they?
Right. But if you-
Yeah.
but if
Well,
you-
what else could we do, Leslie?
We could tape
The
them.
creative compression garment guru.
that's
What else
tomorrow.
would we do? So what else could we do if our
Oh.
patient really didn't want one of those one-legged panties?
Bike
Yeah,
shorts.
great. Let's
Well, I like
say,
the-
pull on your thigh high, and for the
Mhm.
hours in the day that you can bear to wear it, pull those bike shorts on over the top and let's help that fluid get
Right.
to where it's potentially going.
Or use
rather
some of
than-
the textured garments.
Yeah.
You know, some of those textured garments could do a really nice job at creating pressure differentials, and then it doesn't have to be quite so tight. So giving
Absolutely.
them the option to go back and forth between a textured garment and maybe a more flat type of a garment, or, you know, a flat knit garment, which I call the workhorse most of the time, but they can go back and forth between the workhorse and the textured garment and start to make some changes, because they really need to lengthen that tissue if it's starting to get thick.
Yeah, that's right. Yep.
Soften, lengthen.
And if you're in your thigh high, do some massage, get that fluid moving across that pubic region, get it moving around to that gluteal region.
I-
Okay.
Can I just say,
Yes.
I have a different spin on this, only because you have mild pitting edema in the lateral malleoli. I wouldn't go with the bike short because you're going to bottleneck.
I beg your
Yeah.
pardon. Sorry, I don't mean a bike short in isolation. I would always garment from the most distal point of the swelling. So it would be a thigh. If she was in a bike short, it would be in combination with her thigh high garment. Absolutely. Never in the bike short alone, because you're quite right. You're going to push all that fluid down into the lower leg and exacerbate the lower leg swelling. Thank you for pointing that out. Okay, so on her body chart, where do we think, we're not going to talk about scars, we're going to talk about drainage regions. Where are most likely for Skye based on our evidence with ICG research, but also her clinical signs. There are some really good clues in there about where her drainage regions might be. knowing that tissue can feel thick where there is dermal backflow present.
Alrighty. So my interpretation of what I read here is that where I want to create a passageway is the contralateral side, because you have that dermal thickening in the gluteal. So you'll want to go contralateral on both the front, the anterior, and the posterior.
Yeah, so I guess we're part of this research, it sort of almost disproves the fact that as therapists, we're able to create pathways. Actually, I think what our role is to facilitate the body's naturally occurring compensations by understanding some of these principles. So I absolutely agree for Skye that we would be taking fluid across her pubic region, but not because we think we're creating that as a pathway, but because we think her body's taking it there anyway. And why do we think that her body's taking it to the contralateral inguinal region? She has fullness across the pubic region, and that can be a really good indication that that's the way her body's taking that fluid across her mons pubis. In fact, when I was writing this, I had a little laugh to myself because I did a typo when I wrote MOMS across her mum's pubic region, and we don't spell mum with an O in Australia, so I kind of had a bit of a giggle and then fixed my typo and moved on. Where else do we think she may be draining to based on her clinical presentation and our understanding of where cancer-related legs often drain to? Her gluteal drainage region, which tends to be, I'm just going to show you, sorry, fairly high on the buttock, usually around about there. And that's Hiraswami's work looking at these perforating bundles. That is actually a common point for a little bundle to jump through the muscle there.
And is that an indication? And when you talk about that, are you saying that that's likely where it's communicating with the deep lymphatic system?
Correct.
That's why there's no nodes, but it's
correct.
somehow...
It's going down to those deeper vessels. And then once it goes deep, it'll be finding lymph nodes in the pelvis so that all of that nice lymph node action can happen.
So if you feel firmness in like the gluteal area, is that like a good indication that you'd want to drain
It
to
can
that
be.
area?
Yeah, absolutely. Yeah. And there's one more drainage region for Skye where she may well still have drainage maintained, and that's the ipsilateral inguinal. Awesome. So of what you know of our massage sequences, which of those sequences would you be using? The simple one, draining to a ipsilateral inguinal, Katrina, thank you. The complex sequence, so clearing across her pubic region and around to the gluteal region. But first, and I think we had a question from somebody on Zoom, with our massage sequences, do we start with deep breathing and abdominal clearance? Yes, we do. We instruct our patient to do all of that deep work, and then we move on to clearing proximal to the drainage region before moving further down the limb. Now, compression garments, we've already had a nice chat about those. Does anybody have anything else they'd like to add to compression garment? What fabric will we be prescribing for Skye? What do you reckon? Flat knit, I would, absolutely. Yeah, what sort of classes would you be putting somebody in with a cancer-related full leg swelling? Beautiful. Me too. Minimum of a class 3 where there's widespread dermal backflow in a limb, or in a lower limb, a little bit different from an arm where we'd be more likely to look at a class 2 flat knit. Yep. Would we do a toe cap for Skye? Maybe not in the first instance. She's got negative stemocine. Nothing specific about toe swelling, but if we're asking that she goes into a thigh high and bike short combination, We might want to be kind in the first instance and say, let's not do the toe cap and we'll keep an eye on your toes. And if we feel that we need to introduce that at a later stage, let's do that then. Fantastic. Now looking at Sky's goals, how else can we use ICG research to guide some of the recommendations in education that we give to Sky?
I was just saying, just exercise and the whole CDT protocol.
Absolutely, yeah. With a volumetric difference that Sky has, it would be best practice for us to recommend some form of decongestion prior to transitioning to compression garments. So again, it's all of our evidence-based CDT principles that also come into play. So ICG research doesn't supersede any of that. We're still using all of those principles, but we're using ICG as a way of just helping us to know where it's going and how it's getting there. It's like being an Uber driver. If an Uber turned up and they said, I got no idea where you're going, lady, and I have no idea how I'm going to get there, you'd go, oh, I'm not sure about getting in your car. But, you know, to instill some really good confidence, GPS, it is like having a GPS.
So Robbie, if it's pelvic lymph node dissection, are you looking to do a pantyhose because of the propensity or the likelihood of having the other leg affected?
It's not that the other leg will be affected, it's that the drainage from the affected leg may well not be draining into the inguinal nodes anymore. The dermal backflow may well be extending up and beyond and onto the torso. So by putting her in a one-legged panty, we're actually helping to compress and get the fluid, helping to facilitate movement of fluid to those regions.
I actually had a patient who actually started to develop it into the other leg.
And had she had a pelvic node dissection?
Yes.
Yeah, and so I guess our patients with cancer-related lower limb lymphedema, it's sometimes helpful to understand more about the surgery that they had and where those lymph nodes were taken, because if she had lymph nodes taken on from both sides of the pelvis, she may well have had lymphatic impairment in both of her legs to some degree. Is part of the, yeah, and that's not uncommon to see. Yeah. So in that instance, you might garment her pantyhose, 2 thigh highs, bike short. There's lots of options. Yeah, depending on level of function.
It looks like the other groups are finishing up. I see them starting to come upstairs.
Fabulous.
Searching for lunch.
Super. I'm more than sorry. I am aware that this workshop was a little bit short. Very happy to chat to people at lunchtime. Very happy to answer any other questions you might have.
Fantastic.